And we begin with three presenters from Kent, who are in no particular order. Nichola Gardner, who's Assistant Director of Transformation, Kent Community Health NHS Trust. She's an organisational psychologist and executive coach, and the author of the Department of Health's report on arts and creativity, entitled The Art of Good Health. Jo Frazer is a manager of the Health and Social Care Integration Programme. She has a track record in delivering change projects with a background in project management in both statutory and voluntary sectors. And Sue Excell is a qualified social worker and has for the last 13 years worked as a service locality manager for adult and older adult mental health services in the Kent and Medway Partnership Trust. She's now working to deliver health and social care integration across Kent. And their title this afternoon is Health and Social Care Integration in Kent. This is not a day trip. Thank you.
Lovely. Thank you very much. So that's who we are. We won't reintroduce ourselves because it's been done so well. We're really glad to be here this afternoon to talk to you about actually what's happening in Kent. I don't know how many of you realise that the King's Fund have actually identified that there are over 175 different definitions for integration. So this afternoon, what we want to do is go through some of the key things that we're doing in Kent to make our definition of integration a success. We're going to start by just very quickly touching on what the drivers are for change. I think most of us are aware of these now, and it's important to say that these aren't just financial, although obviously there is an element of looking for efficiencies in the current climate they're in terms of looking at health and social care integration. So what the King's Fund have done is identified some of the potential benefits of around being better outcomes for people, making more efficient use of existing resources, and actually improving the access to, experience of, and satisfaction with health and social care services. And what this really means on the ground is if we get this right, we'll have people living more independently at home, maximising their choice and control, and also avoiding duplication, ensuring that people are seen at the right place, they receive the right care in the right place by the right people. You will all know, I think, that a few weeks ago, the Department of Health issued their integration framework, the shared commitment. Alongside that are the Pioneer programme, which we really hope will provide the structure and learning for the next 5 years around integration. And I can say that Kent will be looking to submit a Pioneer bid. So I'm going to hand over to Nichola, who's going to... No, I'm not. I've jumped ahead. It's still me. So they're the drivers in terms of why we're doing it. But actually our vision in Kent is really very much centred around people and the outcomes for people. So these are some of the things that people in Kent have said. I'm conscious that we had Torbay speaking earlier, and you'll recognise these as being some of the same elements. I think none of us would find anything up here that we wouldn't disagree with. So they want to ensure that there are no gaps in their care, that people are always kept informed, that they know who's in charge in terms of care and who to contact and what's in their own care plan. Making sure that they're not repeating themselves lots and lots to different people, and really being clear that there's a plan in place to help me cope if things get worse, and if I need to go into hospital or into long-term care, that actually I can do that if I want to, but I don't have to. The plan's in place to ensure that I stay at home. And this is very much aligned to the work that National Voices have been doing, and they're making it real. And I wanted to share with you, I don't know how many of you have seen the shared commitment document, but their statement, their vision in there, I think really encapsulate what people are saying in terms of in Kent. So they say, I can plan my care with people who work together to understand me and my carer, allowing me control and bringing together services to achieve the outcomes that are important to me. So that's fundamentally at the centre of what we're doing in Kent. And now Nichola will talk through about some of the foundations around how we're taking it forward.
Good afternoon. So where did we start with integrating health and social care in Kent? Well, we decided we'd all been reorganised that many times, and looking forward we'll probably be reorganised that many times again, and I'm sure everybody in this room will be very familiar with that feeling, that we weren't going to start with structure. We wanted to ground our health and social care integration in what it really means for our local people, our local communities, our local patients. So at the heart of our organisational compact, we talked with our local patients, our local clients, and we developed a story. It's actually quite a long story, and we did have a lovely video of it, but our time got a bit curtailed today, so we haven't brought it with us, but it is available if anybody would like to see that video, and I think it's on our website as well. So we've grounded our organisational compact between our three organisations, Kent County Council, Kent Community Health Trust and Kent and Medway Partnership Trust, which is a joint mental health and social care trust, in what it means for our patients. So we're looking at really how do we change clinical practice, how do we change social care practice, what is it that we need to do on the ground. We're not obsessing over who's going to be running the HR department, who's going to have what contract. Those things we expect will come in time, but really for our patients, for the people who receive our services, all of that's pretty meaningless. What they want to know about is, why have I got 5 different people coming through my door all day long, and I want to go out and go down to the market, and I can't because all of these people keep coming through and they're all asking me the same questions. So we're trying to do away with that kind of level of duplication and have a better kind of experience, less confusion through the system. Along the way, we will have to deal with some of these nitty-gritty problems, things like information governance, the IT issues, and we are dealing with those. We have groups that are looking at each of those in turn and seeking to learn from some other areas like Torbay, like some of the London boroughs who are advancing this work also. So we grounded all of this work in an organisational compact between the three organisations. It's a 4-page document. It covers, as I said, our patient story, our vision, the benefits, outcomes, and our approach, which was very much about getting it right with the practitioners first. And we spelt out in that document our 3 key deliverables. And really what these are about is about wrapping our support around our communities, around the patient and their carer and their GP, and taking a journey through to independence. We start with trying to find the right people through risk stratification. We've agreed throughout Kent that each of our CCGs will be using risk stratification. Then we move into the care teams that will support people who are found through the risk stratification, and we're creating integrated neighbourhood teams here. They're a little bit different in each of the different CCG areas. We have 8 CCGs in Kent and Medway. And we're also supporting this with new care pathways, new long-term condition care pathways, new forms of self-care, including teletechnology and health trainers. What underpins all of this, of course, is the need to streamline, not just for the patient and to take out all of that confusion about the 5 different people coming through the door, but also because we all have our financial limitations these days. At Kent Community Trust, where I work, we have an £11 million cost improvement programme year on year. So all of this is very much rooted with trying to make best value from the money that we spend. And we're doing that through looking at decreasing hospital admissions and A&E attendances through this more integrated way of working, so that there's less pressure on the system and it's less reactive. And we've grounded this in our compact with 3 very simple rules: that the people and the communities that we serve always come first, that we will try not to haggle over too many arguments and remain solution focused, and that an agreement is an agreement. So when we started this work, which was probably about 2 years ago now, we had one big centrally driven project across Kent, and that really did help us to bring together all the different stakeholders to create the vision, to develop the compact, to ensure that we had engagement all across Kent, and that we had a framework for delivery with good programme management. But about a year or so ago, we realised that we needed to move away from this centrally driven programme, and I guess that's our first tip for the day. Don't stick with the framework that you're necessarily given from the beginning. Keep talking to your stakeholders, keep talking to your staff, and flex to what it needs to be. When we started this, we had 2 PCTs, 1 county council, no community health trust. Now we've got community health trusts, we've got 8 CCGs and 8 health and wellbeing boards. So we've had to change, we've had to adapt, we've had to localise the work that we're doing. So we now have a programme which has a central framework underpinned by that compact, but which is delivered very differently in each of our CCG areas. I've included 8 here because there's also Medway. And we had to tailor that to the needs of each of those different areas. But there are some fundamentals throughout those. So each area has a steering group that involves the CCG as well as our 3 partners. And we do have the programme management that keeps us all in line, make sure that we're performing, that there's a line of accountability, that we've got the corporate support that we need from communications, for example, or IT, and that we have a forum for learning and sharing. So this gives you a bit of a clue as to the size and scale of Kent and why this is quite a complex programme and why we've had to localise. As you can see, we've got these 7, 8 different CCGs, and Kent is huge. That's one of the reasons why we called this presentation, "This is not a day trip." To get around Kent certainly takes longer than a day. And we have the sea on all 3 sides. So we have a little bit of everything in our patch. We have some areas of great affluence, some cities like Canterbury, very historical centres, but we also have very rural areas, very isolated areas, and some of the seaside towns which have traditionally been very deprived but are actually undergoing a renaissance now. Which gives you the clue as to why we've had to take such a kind of a diverse approach. And that approach we've set out in what we call our integration jigsaw, which we'll now explain to you. And I'm going to hand over to Sue to take you through the first steps of that.
Good afternoon, everybody. This diagram represents our integrated jigsaw, which is a key part of our compact. It aims to provide practical and centred outcomes. And all the pieces need to come together, but it doesn't necessarily mean we work on them in a systemic way. It's the final piece that plays the key part. What we're trying to do on our first piece is to be very, very person-centred, patient-centred, looking at developing registers within primary care, looking at integrated referral systems. I'll come on to a bit more about risk stratification in just a second, but also focusing very much on the principles of sharing our care for patients across 3 organisations. So just to say a little bit more about each of them, the assessment and planning pieces together the shared care, and the delivery care is about trying out different approaches of integration. What we say in Kent is, it's not so much evidence-based practice, it's about practice-based learning. That is what we think is one of our key principles. So just looking at some of our key ingredients, we're going to be looking at risk stratification, which is basically a tool that is based on the KINS Fund predictive model. And this is being populated in Kent in primary care. The aim of this tool is to identify patients at risk of emergency admissions to secondary acute care over a period of 12 months. This is a key tool that's identifying patients that are most at risk in our integrated care teams. GP clinical engagement is our top tip. It's crucial from the outset. Just to give you a little bit more of a flavour of why we risk stratify patients, is to gain a thorough understanding of how risk of future hospital admissions varies across the population of Kent. Health, social care interventions can be targeted at key individuals, A, who are most at need, and who would benefit the most. And by doing so, risk stratification facilitates proactive healthcare and supports equity and efficiency of service delivery, or at least that's what we believe in Kent. I'm going to hand you back to Jo.
Thank you. So we're talking you through some of the key ingredients that we have. The integration jigsaw that you saw, I think you'll get copies of the slides. We're not picking out every single one of those, just so you realise, because we've only got half an hour. I'm sure you don't want us to talk for too long. But under assessment and planning, what we've picked out is the integrated anticipatory care plan. Now, in Kent, we really see the power of the way we're working in an integrated teams being around the anticipatory care plan. That's not to say that we don't think that shared assessment, common assessment frameworks, ensuring that we can only ask people the same things once, in terms of ways of working, isn't important. But there are lots of things around common assessment frameworks, one single assessment, that I'm sure you've all discovered in terms of IT solutions. We work on different systems. In Kent, we're working as a partnership, but we're not coming together as one organisation. We're not having integrated management structures. So for us, in terms of being creative and looking for solutions, we felt that actually developing an integrated anticipatory care plan, which really says what's going to happen for the person, is where the real strength of integration can lie. And it's anticipatory, so it tells me what's going to happen if I should go into crisis. We're very much looking at what are called zero-based care plans. I don't know if any of you in the room have heard that term, but it's really saying actually we're starting from a point where self-management and self-care come first. So instead of it being about what services we put in, or it's about actually what can you do for yourself? How can the voluntary sector help? How can you look at some of the technologies that are here today? How can you look at, iPhone apps, etc.? So we start from a point where actually everybody's care plan includes an element that says how they're going to self-care, how they're going to self-manage. And we are saying that everyone that comes through one of the integrated teams will have an anticipatory care plan. And the top tip that we've got is around using technology, being mobile. In Kent, we have two pilot sites where we're piloting a web-based system called Patients Know Best. It's an online tool, and we've put our anticipatory care plan up there, and basically it allows the patient to share that care plan with their GP, with acute hospitals, with other agencies, if they want to. They're very much in control of it. So in South Kent Coast and Swale, we've started that process of encouraging patients to think about actually, instead of having a traditional model where you aren't in control, you very much can use Patients Knows Best as that vehicle. And the other element, top tip, is accepting it's a journey. I'm laughing because we've only been working on anticipatory care plans not even for a year. And if I tell you we're on version 13 already, and we know that that's not going to be the last version. So don't be afraid of constantly learning, developing. You won't get it right first time, and that's okay. And people want different things from the paperwork, from the way we work together, but there is often a way to get through that and to move forward. So the other element of our ingredients around delivery of care is looking at personalised integrated budgets. So we are in Kent a pilot site. Kent loves a pilot, you'll spot this in this presentation, but we are a pilot for Going Further Faster, which is the Integrated Personal Budgets project, and South Kent Coast are looking at developing, having 25 people to have an integrated personal budget, and then they will be working with brokers to identify how to spend that budget. Now, when we say integrated, Kent is actually, it's what we call a dual carriageway system. So somebody may have an existing social care budget, or they may actually be being assessed for a personal budget. And at the same time, they will then have an assessment and be allocated a personal health budget. And they will come together at the point of delivery. So we have a tool in Kent called the Kent Card, which allows people to have direct payments onto I should have brought one, onto like a credit card, and that's how they can pay and spend their personal budget. So, but actually, until that point, the budgets aren't pooled. They're separate systems, and they come together at the end. So it looks seamless to the service user. They don't realise until that last point. They just see the end game, which is why the top tip is don't think it's all about systems. Give this a go. It can work. All sorts of things get thrown up as you're debating and talking about how this will happen, but actually there are ways to get around those. It isn't all about systems. If there's one thing you leave this room, I think we're all keen to say that don't let the IT systems, the barriers that constantly come up, hold you back. It should be about people and practice and changing how you do things on the ground. And thinking creatively about those possible barriers that are there. So get people in a room, you can find a way to come up with solutions. Nicola's going to go through the next bits of the jigsaw.
So moving on from systems, it is all really about people, and that's where we started with our organisational compact and with our patient story. And that's really where we've come to in going through the jigsaw with you today. It is really about MDTs, multidisciplinary team meetings, and working together. We haven't put everybody on the same contract. We are all still working for different organisations. Who knows what the future will bring in terms of organisational forms. But what is important is that the people in the room together work together as a team, and they're focused on the patient, the client, the carer, the family around that person. So in some places we are trying to co-locate our various teams if we've got the room to do that, but also we're not getting too hung up on that because we recognise that today we live in a very mobile world, and in fact it's not about having people sat on chairs behind PCs. It's about people being out there with technological solutions, which I believe you've got leaflets on your chairs from Advanced Health+Care who provides some of those, and in fact are providing our community information system. So it's about getting people out there and being very mobile to the extent where we're actually holding some of our MDTs in patients' homes. Rather than make the patient and their carer come into one of our buildings, we try and go out to them so that we are guests in their home. So it's about the care that's around them, and that they're having their decisions, their concerns, their ideas about how they want their care package to come together to be very much centred on them. We're also bringing together our teams where we can in these neighbourhoods centred around CCG localities. And what's critical there is despite everybody still belonging to a different organisation, we are all together. So that involves health, community health, mental health, social care, the GP, health trainers, the voluntary sector, and an extended network of people in the local communities. Now, what brings all this together? What is our magic tip here? It's our health and social care coordinators. We have, as Jo said, a bit of a predilection for pilots in Kent. So we have 3 pilots going on for health and social care coordinators. These are the people that bring the jigsaw together. So we have them in Swale, in West Kent and in Canterbury at the moment, but the intention is that over time that will be an initiative that will just roll out across the whole of the county. Now these are unqualified staff. Although I say unqualified, they're highly qualified in knowing their local communities, in knowing their local GPs, in knowing how to get around the system. They're the kind of the magic ingredients, as it were, and they really are the navigators of the system. They offer direct contact for the GP into the community services, into the social care services, into the mental health services. At the moment, they're not dealing directly with the public, but that's something we will be looking to extend to. And the GP feedback has been very good. The GPs really like having this person who knows their way around the system and can make all the connections for and with them. The other thing that's really important about our MDTs is it's not just the place where all those different ingredients come together, where we put together the anticipatory care plans, where we look at the personalised care budgets, where we undertake single assessments using the same documentation across all of our organisations now. But it's also the place where we learn together, and we're putting together and have done all the way from the beginning a series of engagement sessions for our staff and also joint training. So these teams really are at the heart of what we're trying to do. And Joe's now going to talk to you a little bit more about how we're making it work through those teams.
Thank you. I'm just going to kind of wrap it up now in terms of what we're doing, because I'm aware we're close to time and you might have some questions. So this is really just about how we finally make it work, making it real. We've been talking, I've been having conversations recently about actually for this, we need to break through what we're calling a kind of invisible barrier. You know, we've all had change programs where things happen and it doesn't quite work on the ground, but we need to make a fundamental change to the way we're delivering our services and the way we're working together. And we need to make sure that we do that in a way that really changes how people are doing things on the ground. So then we get the better outcomes for the person that we're all looking to serve. So there are a number of challenges and barriers, and some we need to work together to resolve, and some we're hoping that we can work, in terms of the new Pioneer programme and the Department of Health's framework. But the crucial, as I've said, is being creative. So the key things are around making it real in practice. We've talked about the MDTs, we've talked about anticipatory care plans. Integrated contacts and referrals I'll touch on very quickly. We don't call them a single point of access in Kent, partly because we have 7 CCG areas, so and actually in some of those CCG areas they want more than one. So we realised quite quickly it wasn't going to be a single point of access. It's about having integrated contacts and referrals at the front end. So in Dartford, Gravesham and Swanley, we're co-locating the Community Health's local referral unit and the Social Care's local referral management service now sit together. And to start with, for GPs, all the referrals come in via the LRU, and there are processes for what we do in the background. But we'll gradually build on that to extend out and have ultimately joint integrated contacts and referrals from the public, from everybody. Absolutely central to what we're doing is having mental health here. There's no health without mental health. And Sue, I don't know if do you want to say anything, just very quickly touch on that?
What we're doing in Kent is moving away from having secondary mental health services, and we're developing models that are primary care based. So all of our mental health nurses and practitioners are aligned to clusters of GP surgeries where they're undertaking timely assessments and diagnosis of people with dementia and other sort of multiple long-term conditions with mental health and other comorbidities. With the shared care protocol shortly on our horizon, our mental health practitioners will also be undertaking medication reviews to support the GPs on an annual basis. So we've kind of, if you go back to the jigsaw that I kind of sort of swooped over in places, but if you go back to the first stage, the first piece of the jigsaw is very much about some of our services coming away from secondary care and bringing them right out to the forefront of where services need to be delivered, which is very much primary care based. Thank you.
Thank you. Workforce, so Nichola touched on it, so we do have a joint human resources plan, we do have are developing a joint training plan, and we also have a staff guide that I also know Leeds have done, and I'm sure other areas, but so our staff really feel informed and engaged in terms of what we're doing around integration. We're having a number of staff engagement events. And it's important to listen to what they're telling us as well. It's not just us giving them out information. The staff engagement events are us about hearing what they're saying so we can make change. Key performance indicators, they're not onerous. We do have to have them. We also want in Kent to have an evaluation framework which includes looking at some of those financial savings and efficiencies we've been talking about. And I'm not going to touch on information governance because I suspect lots of people have talked about that. We have found a way of working with that. We do have an information governance agreement between the 3 organisations. We have training for staff. And as I say, it's about being creative. It's not about kind of giving up at the first element where, it's a jigsaw, we said. If a piece doesn't fit, you try it somewhere else, and eventually the whole picture will come together. And in Kent, it looks like this.
Thank you very much. I think we've got time for probably one question at least. Anyone? Yes, gentleman at the front. Can we...
Hi, my name's Jonathan Bradley, and I'm part of an integrated care programme in Eastern Cheshire called Caring Together. Our approach is very much based around campaigning and social mobilisation. You haven't mentioned that, but I'm sure it's a big part of it. So have you got anything to sort of bring out in that sense?
Do you mean in terms of engagement with the public, or...?
Public, carers, staff.
Yeah, I mean, in terms of, as I've said, absolutely at the centre is patient engagement and all stakeholder engagement. All of the locality steering groups that Nichola mentioned, several of them, I can't say all, several of them have patient reps on that, but we have a wider network of people that can be engaged and involved. We hold regular stakeholder engagement events with the public, and actually some of those events have been mixed, so it's voluntary sector, public, staff, anyone kind of with an interest in terms of health and social care integration. And actually there's an event taking place next week on the 19th of June down in Sandgate as well, which is open to people to come and talk about health and social care integration. I don't know if you want to say anything more.
Just to say regarding the mental health, going back to 2010, we had a lot of public forums that were open where we asked carers to come along and talk about services they expected for people with mental health problems and people with dementia. And it was for that reason that we then started to look at coming out of secondary care, because people were telling us, we don't want to come into secondary care, we don't want a diagnosis of dementia and mental health. We want it where we get a diagnosis of our diabetes, which is our GP surgery. So a lot of the integration and the areas that we've been working on that are inclusive of mental health are very much on the back foot of what the public have said they wanted locally. Is that all right? Okay.
Just very quickly, one other thing that I've just thought of is we also have the Community Health Trust does a survey with patients, and that includes a question around their experience of integration. And within social care, we also have a user survey which goes out, and we've added questions around what people's experience of integrated care is as well.
Okay, we'll need to move on now, but thank you very much for the presentation. Thank you.